All right. So this webinar is practitioner researchers, strategies for conducting community participation research, and we are presenting it as the Temple University Collaborative on Community Inclusion. So what are we going to cover? These are some things that we thought were the main points that we wanted to get across when developing this. We want you to come away with really the idea of be able to identify what the value of practitioner-driven community participation research is. So come away with really an argument as to why you should, as a practitioner, engage in this type of research. We also will help identify some strategies for engaging in research, and then we're going to challenge you to develop a personal goal for really starting a practitioner-driven research plan. And we'll start by defining some terms.
So one of the first places that we can begin, as the collaborative, we really do focus on community participation. We're focused on adults with serious mental illness and their engagement in the community, mainly because we increasingly are arguing, and I believe the evidence exists, that that community participation really is a medical necessity, and it produces a number of important outcomes. In its broadest sense, community participation really involves the opportunities to engage in meaningful activities in one's own community, just like anyone else in a community. People with mental health conditions consistently identify that this is an important aspect of their lives, and really are interested in being engaged in it. When we start to argue this as a medical necessity, it's a lot of times based on the outcomes from community participation, and the role that they play in physical health and mental health and in social health is really quite well established. And the other thing that we're looking at is that increasingly this is becoming a goal of many mental health programs and community mental health programs. And so figuring out how to identify and how to do research on community participation, the outcomes of community participation, as well as those things that contribute to it, becomes important.
And then, of course, what is research? I like this little guy in the corner because, you know, he's sort of what many people think of when they think of research. I sometimes hearken back to my science class when I was a kid and the science experiments that we would do. But really, it is, you know, it seems like it's a difficult concept, but it's not. It's organized and systematic approach to answering questions. You'll notice that the things that are underlined are pretty consistent. So there's the careful consideration of a concern or a particular problem. So it's really identifying what the need is and then figuring out a way to not haphazardly, but really systematically answer the question. It's also a process that entails the collection of data, documenting the information that matters, and then really analyzing and interpreting that data to address the concern or problem that was identified. And then, you know, in sort of lay terms, it's really just a way to determine and document what works and what doesn't work.
One of the things that we can compare, when we think of research, a lot of times people think of basic research and laboratory science. There's certainly value to laboratory research. It has this high degree of control, and this relates to really good internal validity, meaning that when we try out something or an intervention in a laboratory in a highly controlled situation, we have a sense that the intervention itself produces the outcomes in a highly controlled situation. The problem is that it also compromises the concept of external validity, in which the question is, okay, so you can produce this in a lab. Can this be produced in the real world and in field settings? Gretchen enjoys the cartoon, so I always have this one in my research class because, you know, research study shows that Oreos are more addictive than cocaine, and the rats are saying, dude, I hope this experiment never ends.
It's so true.
Yeah. In contrast, research in the community and in field-based settings has much less control. It's much more difficult to control all the extraneous variables that go into it, which can be a threat or weaken internal validity in terms of really knowing whether or not, what is it that's happening here that really produces the outcome we're looking for. At the same time, field-based and community-based research really can enhance external validity in the sense that what we can find in one situation or one setting, the effects that can be derived in one community mental health setting may be more easily applied in another community mental health setting, because the realities of practice are much more similar from one community mental health setting to another than they are from one laboratory or university research hospital to a community-based setting.
But the other thing to note here is that even research in the community still has a certain level of control that doesn't exist in typical service settings. So for example, the research that we design here with the collaborative, we're often able to identify who we want as who can be in the study, so who can participate in it. We also have certain exclusion criteria, so we're leaving some people out. We're really defining different things. While it's a little less controlled than what happens in a laboratory, we still have the ability to have a little bit more control in terms of what the features of the study are. And then that kind of leads to, what is this idea of practice-based evidence or practitioner-driven research? And I liked this quote. It was from a physical therapist. And she said it was, it's the real messy, complicated world is not controlled. Instead, real-world practice is documented and measured just as it occurs, warts and all. So it's recognizing that, the space where, even if they're evidence-based practices that were designed in research studies, the place where these things then happen don't have that level of control. And there's a lot of different factors that you want to be able to then look at and evaluate. And so research that is practitioner-driven looks at and documents the processes and outcomes of interventions and practices. It can really answer questions about how an intervention works, and that how is an important piece, and how it works with clients who might have particular characteristics. It can also identify external validity of basic science, and basically that's saying, does this work in the real world?
And this is also, for those of you who may be familiar with the idea of evidence-based practice, this is really somewhat of a reversal, because evidence-based practice historically is focused really on how do you take scientific research, much of it highly controlled laboratory research, and apply it in practice. And this practice-based evidence takes a somewhat different view, and that says that practice really does help us to understand the evidence around what's effective and with whom and under what circumstances. And so this idea of practice-based evidence is newer than evidence-based practice, but one that has really gained a fair amount of attention in the last 5 to 10 years.
And it makes a lot of sense, because as practitioners, you do and you continue to do what seems to work best for your participants or your clients. And practice-based evidence is really taking that to the next level and saying, all right, you've got this great program, people love it, they engage, they seem to do better, their documentation shows that they do better, so why not actually document it and then share it and see if it's replicable in other areas. And so it's helping to inform the research world so that communication can be bidirectional. Okay, so we're going to move into kind of the meat of the presentation, which is really digging into how and why practitioners might choose to engage in research. Oops.
So some of the ways that practitioners may already be engaged in research really is a part of everyday routine practice. There's a particular systems model called assess, plan, implement, evaluate that many interventions as well as treatment programs are based on this concept of measuring at the baseline, which really is consistent with a research paradigm. This idea of identifying a baseline condition and an outcome goal through an assessment process is already something that most practitioners do while providing services. When we think about the concept of experimentation, really this is the implementation of an intervention. So we've identified a state with a desired outcome goal, now we're going to intervene on that with some sort of treatment. And then through reassessment, we actually can then evaluate the outcome of that process. And so through this idea of assessing, planning, implementing, and evaluating this cyclical system, we actually can address many of the things that are part of the research model that are already being done in practice. One of the things that I also like to think about is that in many ways we, as practitioners, are oftentimes involved in some sort of evaluative process. And the thing I think that's important is that evaluation really is a similar phenomenon to research, and in that it uses much of the same tools. But Sherlock, back in 1995, commented really on something that I think makes a great deal of sense, and that is that when we do evaluation, evaluation is decision oriented. We're typically trying to make a decision about the value of a program, continuing a program, modifying a treatment. So evaluation really is based on making decisions about something, whereas research tries to reach conclusions about things. Does this intervention work for different people as opposed to just one individual client? Are we effective in our programs in producing changes in whether it's physiological health, social connections, community participation broadly? And so really through research, we can reach conclusions about things, but the tools are much the same.
So the next question is really, why then should, that should be practitioners, why then should, oh, we have a question. Not clear about the distinction between decision and conclusion.
Sure. So in most research approaches, what we're trying to do is generalize from a sample or an experience to a population. So conclusion-oriented says, is this intervention effective? So for example, the intervention that Gretchen really developed and we worked on together was an individualized placement and supports intervention. We tested this as an intervention and tried to reach a conclusion as to whether or not, is this an effective intervention? Now, from an evaluation point of view, if we're in a programming model, we'd be working to collect data to identify, does this work in our agency? Is this appropriate for our agency? We can evaluate at the client level as well to make decisions about, do I need to change the intervention for this client? Do I need to modify it? Was the intervention effective for this client? So the idea of evaluation is almost always to make decisions about what is being done. Whereas with research, we're trying to make conclusions that can generalize to broader audiences.
So then why would practitioners decide that they want to engage in research? And this is some of that decision-oriented work, but it can generalize, I think, to the broader system within the organization. And you want to know, is this working? Because we've implemented evidence-based practice, and we know, or we hear sometimes that this just doesn't work for the people that I'm working with, or this, I can't do certain things because of where I'm at. And that's the reality of taking things that are designed in that more controlled environment and implementing them in more real world settings. And so it gives you the opportunity to really look at and say, is this working, and for whom is it working? Because it may work for some folks, but not for others. And by systematically asking that question and evaluating it, you're able to see who's most appropriate within your program and who may not be a good fit. It can also help you to improve your practice. And then there's an opportunity to really share what you know works with others, either within the organization or to then try to inform researchers and let them know what the issues are, the issues might be with something that is assumed to be evidence-based or is evidence-based but may not work perfectly in every natural environment. And then finally, this can help you with your own programming and making sure that opportunities either stay available or have the opportunity to expand, because you're really documenting and demonstrating that something is working or not. And if it's working, it gives you the argument to really say, this is something that we value, our participants value, and it should be continued to offer or even expanded.
So one of the advantages of
Sorry. You're in control of this.
So one of the reasons that practitioner-based research really provides some additional information to the body of knowledge really has to do with the perspective that practitioners have that may be different from people who are full-time researchers. And that really is that practitioners have a good sense of the context in which things happen. The idea that we shouldn't avoid research because the environment, the real world, is messy. We actually should engage in it for that very reason. The idea that things that are demonstrated in clinical trials are in highly controlled environments. But the question is, to what extent do these really work in real environments? I think of one of the examples of, for example, when individualized placement and supports models, particularly around supported employment, came out, there were a number of trials of this that were seen as really an evidence-based practice. But when put into practice by a clinical psychologist in Texas, realized that his caseload was 4 times the level of what was done in the clinical trials. And so the challenge of taking what's done in a controlled trial and applying it in the real world helps us to really understand a lot more about the realities of implementing these. As Gretchen had mentioned earlier, one of the other things that we also deal with is that practitioners don't have the idea of inclusion and exclusion criteria oftentimes. We take, as a practitioner, and having worked as a practitioner earlier in my life, we take who comes through the door next. And so this really makes it more of a real check on whether or not does this work with a variety of individuals. Practitioners also have real restrictions within agencies. What are the things that we can and can't do? This is one of the challenges that anytime we're working in an agency, funding is a big issue. And is this a billable or reimbursable or a covered service becomes a real part of the restriction in terms of what we can and can't do and how we do it. One of the other really important reasons I think that practitioners can and should be engaged in research has to do with the idea of clinical judgment. One of the things that's oftentimes overlooked in evidence-based practice is that one form of evidence is clinician judgment. And this comes from years, months of experience of knowing what works for whom and how do we tailor things to get the best effect. And so this clinical judgment becomes really an interesting perspective that practitioners bring to the research endeavor. And then finally, practitioners really have a familiarity with institutional and community culture. Not only are we having to employ and deliver services that may be developed in a clinical trial in an institutional culture, but we have to know, and oftentimes do know, something more about the culture of the community and whether or not this any type of intervention will work. This idea of institutional culture is important because, for example, if we're trying to institute a tobacco-free policy and all of our staff are out across the street smoking, it's really challenging when we know that the institutional culture may not support some types of services and interventions that may be shown to be clinically effective, but a challenge to implement in the real world.
Well, and I think, connecting this back to the research side of things, if those things are consistently occurring and it's something that can be documented, or, even in satisfaction surveys where, say, there were a group of participants who were in a smoking cessation program and they said, well, it was really hard because every time I walked out, you walk through a staff cloud of smoke. And so that that starts to document the evidence from a single program to then say, oh, this is another factor to consider when implementing this intervention, whether or not it becomes something that can inform the agency decisions, but it can also be then communicated to a broader community to help make those decisions more intentional by other practitioners.
So one of the things that we want to bring it back to really is focusing on community participation, because that really is the aspect of what we're looking at in terms of where to focus research and practitioner-based research. And as I mentioned at the beginning, the idea of community participation as a medical necessity really derives from the value of community participation on health outcomes, and really becomes potentially one of the targets of practitioner-based research. To what extent can we actually research and document how community participation may play a role in improving health outcomes?
And so just to sort of break down some of the health outcomes that might be related to community participation, here's a whole body of areas that might be targeted and traditional outcomes of mental health services. So we have negative symptoms that are often addressed or we try to address in services. We often look at executive functioning and the skills that are related to that, and we want our participants to come away with better planning skills, time management, organization. We know that there's a need for improved physical activity because of the health conditions that go along, that are common among individuals who have mental health conditions. And then as we've moved into more of a recovery-oriented services, we also look at self-determination, hope, identity, and meaningful activities. And what our belief is, and the research shows it as well, is that community participation or engagement in community participation has the opportunity to really impact these areas.
So the next step really is to start to look at what are some of the tools that we might use and practitioners might use to help really start to conceptualize a research problem and then be able to operationalize that in a study.
So where do we begin? There's a few different things to consider. I'm going to do this backwards, but the things that you are most familiar with would be, what are the assessment timelines, the assessment tools, different databases where this information is entered, client charts, and then the specific details about individual clients. And you do all these things on a daily basis or a periodic basis, a routine basis. But what we're challenging you to do is really think about those things in a new light. Think about the information that you could get from that data or those resources to really answer a specific question. So instead of just, walking through and checking the things off and then using the assessments to develop goals, really think about, is there information in the assessment process that I could then integrate into this research question that I have. So the idea around research is not that you want to add a bunch of stuff to your already heavy workload, but how can you use the things that are already in place to make research a feasible goal. And so then beyond the things that you might be familiar with, there might be some things that you want to look into that you may not know. Are there internal supports at your agency? Some agencies have a director of research, which you may not know if you're in a direct service provider role, because that may not be something that you need to interact with on a day-to-day basis. And you may have heard that there's someone with this title, but you don't really know what they do. Sit down and talk with them. Ask them what their goals are and see if there's an opportunity for you to engage in research with their support. often you can't just start a study. You do need to go through, see if there's a process for a research ethics board or institutional review board approval. If you are doing a project simply for your own program evaluation and you don't intend to share it beyond that, there isn't really a need for going through a research ethics board. But if you want to have the opportunity to use that information and really share it with the broader community, it is best practices to go through a research ethics board. And then are there others? You don't have to, most researchers are not sole researchers. If you look at journal articles, you'll see that there are a slew of people who are involved in projects. And so don't feel like this has to be something that you do independently. Ask around, see if there are others who might be interested in the project. You can ask within agency. If there are local universities, there are likely faculty who would be interested, or even graduate students who might help with some of the project as well.
So one of the tools,
it's very sensitive.
Yeah, it's very sensitive. And so one of the tools that we use and we encourage people to engage in here is what we call a PICOT statement. I don't know how anybody else pronounces that. Maybe it's
PICOT.
Yeah, but it stands for these 5 elements that you want to identify to start to sketch out what is it as a research project or approach that you're interested in taking. And so the P really stands for the population or problem, but a lot of times it is a population and problem. So within a certain population, what is the problem that you're trying to address? The I component identifies what is the intervention that is either being currently done or you would like to evaluate for its outcome. The C represents either a comparison or a control condition. Now, a lot of times in practitioner-based research, it's really difficult to establish control, oftentimes because we can't withhold treatment. And so sometimes the comparison may simply be to treatment as usual versus a group that receives some sort of added component. But we want to identify what the intervention is, and then is there something that is being compared to?
You can also compare within person.
Right. And so that's one of the things too, that we can compare from baseline to endpoint as a comparison. The outcome then is, what is it specifically that you're trying to affect and what are you looking at? And then time frame. What is how long should it take for this intervention to have an effect? This, I think, is really one of the challenges too in a lot of clinical research, is that for a lot of reasons that are based on resources, interventions typically run in 3 or 6 month or 12-month intervals, and the question is this the best time frame to really produce the outcome? Go ahead.
All right, so we'll actually get into this example a little bit more in detail, but we walked through an example using the PICOT format. And so our population and problem is that, and we know that individuals with mental illnesses experience high rates of obesity and heart disease. We want to do, and we've proposed an intervention that is a lifestyle intervention, but there's 2 sort of models of it. There's a lifestyle intervention that happens pretty much within the agency, but then there's lifestyle intervention plus community participation. And so that the comparison then is that standard lifestyle intervention that that occurs in the agency. And then our outcome that we're targeting, we're keeping it simple with physical health outcomes and looking at their body mass index, which is a relationship between height and weight. So we'll just mainly be weighing people and measuring their height at the beginning. Time is, we've identified that this is an ongoing program, and so we wanted to pick a time that reflects a reasonable expectation of change. And there is some research that says that these types of lifestyle interventions should last more than 3 months in order for them to yield statistically significant weight loss for individuals. So we're saying we'll measure at 6 months.
You want to take this one? I'll
Sure.
take the BDI.
Sure. So this example here's a little bit of information about it. It's a fitness program. Actually, it's more of a lifestyle program because it does have nutrition components as well. Participants who are interested in improving their health and wellness are referred to this agency-based program, and it assesses their interests, connects them to community-based resources, and helps them to identify individualized goals. So the program as it exists in our example is that there are 35 individuals who are referred to and in the program. The assessments are conducted on a regular basis within the mental health center, and it looks at this whole group of things: symptoms, goals and interests, weight, recovery, and community participation. The program components include group-based education on fitness, nutrition, and goal setting. Then there's some group and individual fitness classes. There's opportunities to identify, register, and participate in community-based fitness programs. And then there's also a nutrition focus that includes meal planning, grocery shopping, and eating out. And I've underlined really the components that are specific to community participation. So really everything could happen as the standalone program, and then the program plus would be that with the underlined pieces, and the program's ongoing.
Okay. So one of the things that that also helps to work through, in addition to the PICOT statement, is really what are called the behavior determinants intervention logic model. And unlike most conceptual models where they move from left to right, this one actually moves from right to left by beginning on the right-hand side with identifying a health outcome that you're trying to achieve, and then what are the behaviors that contribute to the health outcome? What are the determinants or mediators sometimes that intervene on the behavior? And then what is the intervention? And so what we've identified in this is if we're targeting obesity, and body mass index is an index of obesity, what are the things that contribute to obesity? And we know those to be particularly diet and physical activity are two of the most commonly identified and significant contributors. The determinants may be related to things such as knowledge. Do people know how to know what the contribution their diet or behavior is and what is contributing to their health? Do they have an interest in making any kind of change? And what are their opportunities to actually change behavior? And these then derive and relate to the intervention that we subsequently will identify. And I think Kira just identified
The TCP.
Yeah, the TUCP. One of the other downloads that you have at the beginning of the chat pod today is a behavior determinant logic model for generated from the Centers for Disease Control and Prevention. And this really allows us to further explode the concept into what is it we're trying to target here, and what do we think is really going on? What are the things that are contributing to obesity? And it should be at the very top of the.
I'm just going to re-add it.
Okay. To what are the behaviors that are contributing to obesity? We see healthy diet, we see physical activity, and we see community participation. Those areas on the next, the determinant level, also identifies what do we think is contributing to it. So when it comes to healthy diet, one of the things has to do with knowledge. Do people have the knowledge of what is in their diet? If they're eating a very high sodium diet, do they know this? What about the added sugars that are being consumed? Do they know how much sugar is in the food that they eat? And so part of it is the idea of knowledge may be one of the contributing factors. We also want to take into account that opportunity may be one of the contributing factors. Where do they live? Do they have access to healthy food opportunities, or all they have is access to the corner store that doesn't necessarily have the best food options? And so intervention activities may be related to eating education, meal planning, but also identifying options and opportunities. When we start about physical activity, we add in also interest, simply because physical activity is one of those, I always say physical activity it's a wonder drug. It's an absolute wonder drug. but nobody can tolerate for more than about 30 days. And so, we talk about it as being absolutely, exercise and physical activity are absolutely important, but it's very difficult for people to sustain it. And so if we don't take into account things like interests and support, it's very hard for people to change their physical activity behavior.
Brian, when do you run?
When chased. That's the only time I run. I do not run for any other reason. But I am, it's kind of funny. One of my daughter's friends said, "How does your dad stay in shape?" And she said, "He never stops moving." So, but when we start to look at physical activity, now we have to look at interests and what are the opportunities, just like with healthy diet. And then what is the support for behavior change and sustaining that? And so intervention activities from the example could include fitness, group fitness, individual fitness, and goal setting. And then when it comes to community participation, again, we want to look at things, what are the determinants? Well, there may be interest. People may really not be able to match interest with opportunities, or they may have lost or forgotten interests. And then what supports are available. So when we start to build out this idea of what are we trying to target? Well, it's BMI, but there are some behaviors and determinants in between. And if our intervention is able to target those things, then we're better able to identify and establish and reach conclusions about whether or not our intervention is really contributing to changes in affecting determinants, changes in behavior, and ultimately the health outcome.
And so where do you want to begin? So we've gone through the process of identifying these key components, and that really sets you up to determine what those unique program features are. So there's individual and group components, there's nutrition and fitness components, there's also agency specific components, and then there's community components. So you want to develop an evaluation plan, which for the purposes of this are going to include weight and BMI, and then check and see if the agency required assessment periods fit with your PICO timeline. Ideally they do, because you don't want to try to add something in, because when you add in an additional assessment that doesn't fit with your agency time periods, it's more likely to get missed. And so try to make sure, or try to design it so that you're hitting those time points and including the things that you would like to be measured within your required agency assessment. And then also collect participation data. And since the intervention that, I'm going to go back one slide, maybe. Seems finicky. So these different things here, you can create sort of a log of what people are engaged in. Because, for example, maybe participants are all enrolled in the same program and you don't really have the opportunity to offer different things to different people. But what you can do is you can measure attendance and who was engaged in what. And so what you might end up finding is that there are certain people who were engaged in the agency components, and then there were people who were engaged in the agency and community components. And so by measuring those things, and really, just keeping it as a checklist of attendance or participation, that gives you something to then include in your analysis plan, in comparing the different people and what they were engaged in to what their outcomes are.
So the next step is, how do you determine and analyze the data? I do tell a story that I have taught graduate statistics courses many times. It is the only class I've ever taught where students cried in my class. That did not feel good. But statistics can be understood conceptually as well as mathematically, and I think that's really one of the challenges. This is also probably the area for most practitioners where if they need additional support, this is often an area where that's needed. And it's important to think about too, how you're going to, we begin with the PICOT statement, but how are you going to determine if there was something that happened? This actually has to be part of the question from the very beginning. It's very difficult to do this after the fact. And so it's really good to have somebody who might have, it's quite possible as practitioners, you have very good statistical training. But a lot of times as clinicians, the mathematics and statistics part isn't really the strongest part of our education. And so finding resources or finding someone who can help to answer this question and help you to design things is oftentimes useful. But most analysis basically uses some form of statistics. And essentially what we're trying to do is determine whether or not there are differences between two groups of data. And it's a function of how different the group central tendency or averages are. But that function is also related to how much variation is there within each group. And so it's a combination of this idea of the difference between means, but also as a function of the variability within each group. And so what we see is as the variation within the group goes down, that it's possible that a closer group mean would be found to be different. And so basically what we're trying to determine is we know that anytime we take two measurements, they're going to be different simply by chance measurement and what's called measurement error. The question is are they different enough that they appear to be something other than just a chance occurrence? And that's ultimately what statistics tries to tell us. Is this different statistically significant? The next question then in the analysis is that if it's statistically significant, we have to make a more qualitative decision about whether or not it's clinically significant. That is, we could make a statistically significant reduction in BMI, but it may be such a small reduction that it may not be clinically significant. So something that we have to think about.
So Brian, what is the blue U?
The blue shape represents one distribution of data. And so this may be right here. I don't know where my drawing tools are. Let's see if we can do.
Arrow, pen.
So this would be.
Oops.
Yep. Okay.
Hold on. We can get the. I was drawing all over the place before.
I know.
Annotate. All right. So we should. Yes. I think you can draw now.
All right. So this distribution right here represents the scores of one measurement, and this distribution represents the scores of a different measurement. Now these could be time 1 and time, this is going to be really tough, 2, or it could be group 1 and group 2.
So group 1 could be just the agency-based physical lifestyle program, right. And group 2 could be the community-based program.
Exactly. And so we can compare groups within people over time or between groups as well. And so what we really are looking at is basically the changes in group means, but also considering how much they vary about that mean is important to being able to determine if there's a statistically significant difference. Again, conceptually, the techniques for doing it are things that, believe it or not, Excel now has a statistics package that will run a lot of basic statistics, and it's fairly straightforward.
Oh.
Oh, wasn't expecting that to continue.
No. So the next step then is, what do you do with this information? We say share it. So share it with your program participants. Let them know what works and what doesn't work. It is also something that you can be very transparent and say people who engage in the community components are more likely to lose weight based on, the last few rounds that we've evaluated this. And so it might become something that is motivating for individuals to engage in the full program, and you're really providing more informed information to participants. It's also something to communicate with your agency administrators. Again, this is something that can help you ensure that these programs continue to be available or possibly expanded. It also, is something for your own professional development and gives you the opportunity to share things at conferences or research presentations, and hopefully, helps invigorate what you're doing, and you can keep that momentum going and continue to engage in practitioner-based research.
So next steps, really, we want people to be able to identify some of the things that they might be able to do to make commitments, identify where they might be able to identify what they're interested in and how they might move this forward.
So this is some time for you to do some self-reflection. We will encourage you to share it in the chat box, or you can also unmute yourself and just tell us. But we find that, you know, saying it out loud or writing it down somewhere is more likely to get you to be committed to it. So think about the things that you're interested in. Is there an interesting issue that's experienced by participants that you work with? Is there a particular program at your agency that you would really like to know more about? Are you using really a unique approach to community participation that you'd like to sort of see if it is contributing to health outcomes? The logic model worksheet that Bryan shared earlier, you guys can download and use that to really walk through the different components of the intervention or the determinants of the outcome. And then we would recommend that you develop that PICOT question to help you stay organized, because otherwise it's very easy to start to try to add everything else in and, oh, isn't this interesting? Or, oh, let's add this to the intervention. But really keeping things simple and organized and systematic will help to make sure that it's sorry, I got sidetracked, will help to make sure that you're focused and that it's research and that you're going to be successful in this process. And then share those interests with agency administrators and then look around and see what potential supports might be there.
So the question that was brought up really has to do with the idea of adding additional data collection. And that's absolutely the case. I mean, I definitely recognize how challenging it is to add new data collection items. And I think the idea of using existing data is certainly something you want to do. I think one of the challenges that we sometimes run into with agency level data is, are the instruments something that have been validated? A lot of times we are using sort of agency derived, agency developed sorts of things, and that becomes somewhat of a challenge. So one of the things that I think is the most important is to be able to, if there are routinely collected aspects of data that may be able to help you to answer a question, you're much more likely to be able to be effective on that because it doesn't require people to do anything additional. The other thing, and this is a suggestion I think that's made by the person who raised it. I'm sorry, I'm not sure if this is a first name or a last name, but the idea of using the briefest measure possible, and this is really one of the keys, that anytime, even when we're doing, you know, funded research, we're still trying to minimize burden, because the longer it takes to collect data, the harder it is to collect it. And so the most efficient way to do it is to use existing measures that you can tie interventions to where we should see changes. But if you have to add a measure, strongly encourage going to the least burdensome measure. And the other thing I'll point out too is that there are some really valuable sources of publicly available measures that are available through the NIH Toolkit, through Phoenix, and through rehab measures. And so there are a variety of them.
Jack. Thanks, Jack.
Okay.
So the other comment was that Jack is on a state data and analytics group, and the state does sometimes collect things that are not particularly meaningful and sometimes not particularly accurate. I'm actually on a research group where we're developing some outcome measures, and they were working with a state level organization, and the state basically said, we just need to know what it is we need to measure. We don't particularly care if it's accurate as long as we're meeting state requirements. And so, you know, we've got work to do in terms of, you know, trying to make sure that the best available tools are being used. But sometimes that's not the case.
Yeah. And that's this is an issue that we've seen, and one of the reasons we see so many now data repositories or instrument repositories really has to do with the fact that even academic research, because it uses so many different measures, you can't compare things. And so increasingly the federal government has sought to try and identify consistent measures. The NIH toolkit is one example of that. There are a number of other types of resources for measurement instruments, and I'd be happy to share those after the fact. I don't have those up. I mean, there's the Shirley Ryan Ability Lab, which is in Chicago. There's PROMIS, P-R-O-M-I-S, which is health measures. There's the NIH toolkit, and there's the Phoenix toolkit, all of which have standardized, validated measures. And also some of them are brief measures. So those are some of the places that are good resources if you're looking for measures that have been validated. Yeah.
And yeah, so another comment from Asia is that there's a lot of good data that is gathered, but that the key is really trying to use the data and work with folks within the agency to get the right reports and figure out how to generate the right information. And this is something that we hear a lot, in that we'll go in and we'll partner with agencies and they're collecting wonderful data or they're doing wonderful things, but they don't know what to do with it. And it just kind of goes into the big pot. And so I think it's being intentional and having those conversations, taking the initiative to have the conversations with people within the agency, because it's often, as long as someone starts the conversation and, you know, and is willing to sort of keep pushing and be systematic about it, there's often a lot of interest in doing it. It just takes sort of that push to make it happen.
Yeah, and I'd echo that as well. I agree, Asia, that there is so much data gathered, and a lot of times it takes an opportunity for somebody to really have to work with the IT people to be able to extract what you need to answer questions, and the data may already be there, quite frankly, but it may not always be something that's necessarily important or valued by the funding agencies, which oftentimes is state entities.
So again, this just kind of reiterates what we talked about in the last slide, but I would encourage you to have your own, you know, jot some notes, write it down, make it happen. Yep. So that's that. So we are also here as part of the Temple University Collaborative on Community Inclusion. We are a research and training center. You're participating in a training as part of a training center, but that means that we're available to work with individuals and help them set up some of these plans. We can even provide some support with analyses, depending on what exactly is needed. And as long as there's that focus on community participation, we are happy to work with agencies to figure that out.
Right. And Jack, to answer the question, we're actually a rehabilitation and research training center, funded through the Centers for Community Living, which is a National Institute of Disability, Independent Living, and Rehabilitation Research entity. And so we're an RRTC. And as Gretchen mentioned, I mean, we provide both training and technical assistance and are available for providing technical assistance.
So Shannon had a comment. She's a recreational therapist on an inpatient psych unit where participants are not able to leave the unit. And then there's a need for patients that return frequently. And so she's working on an evidence-based program that eventually plans to research once it's up and running. So I agree, and we've actually had those conversations about how do we reach those populations that we know community participation is going to be important once they're outside of the hospital, but it's difficult to do integrated opportunities for people who can't leave. And so I'm actually really excited to hear that you're doing something with that, and I would love to hear more about it. So if you want to contact us, yeah, you can do that. And I will type our email addresses here because we both realized that we didn't put them in the presentation. Oops, add an extra letter, is my email, and Bryan, Brain.mccormick and yeah, we have done some research with peer support specialists. We actually have a study that we're waiting to get started where we've hired peer support specialists who will be helping with a transportation intervention, where we have both a bike share arm and a public transportation arm. So we're working on training the peer support specialists to really facilitate that intervention. We also work with the Copeland Center, which is a national organization that trains peer support specialists, and they help inform us and make sure that we're keeping things that are consistent with peer support models. Any other questions? We will, this is recorded, so we will make it available once we caption it. We'll post it on our website, and we'll send you guys an email directly, since we have your email from registration. And thank you very much. If you do have questions, do feel free to reach out to us. Our email addresses are above.